my presentation is going to be on the problems, nonunion and malunion of the coronoid and the proximal ulnar fractures. So the common cause of a nonunion is an open high-energy fracture of the proximal ulna, usually with bone loss. Infection can be another reason, pathologic fractures, and as all the previous speakers said before, electron osteotomy can be a cause of a nonunion, and probably the most common reason for this is inadequate fixation. This is an interesting study regarding plate versus tension band wire fixation for the electron fractures, and this study included patients with electron fracture with non-comminuted or a small comminution, and it's interesting to see that both techniques had a good clinical outcome at 3 months, but in total the short glance technique had a higher rate of complication, needing more revisions. And interesting for me that was the loss of reduction in a high rate for the tension band technique needing surgery. When we deal with a patient with a non-union of the proximal ulna, we have to evaluate him thoroughly, clinically, and the imaging, and all the images. We need to check for pain, for reduced range of motion. It's important to see if there is instability of the MCL, and of course we have to evaluate the quality of the soft tissue. If there is bone loss, if there is osteoporosis, disused osteoporosis, arthritis, and we have to keep in mind the infection could be subclinical sometimes. The treatment options for this case is just do nothing for cases that we don't use with low demand patients with a stable non-union, of stable fibers non-union, which is enough for the daily living in these patients. We may use new fixation and use grafts. Excision if there is a small piece, we can excise this low demand patient, and sometimes we have to do an elbow arthroplasty. This is a study from Ring and Jupiter, and they described 10 patients with atrophic non-unions of the proximal ulna as a result of transelectron fracture dislocation. And they used a thorough debridement of at the site of the non-union. They used autologous bone graft, stable fixation of the posterior plate, and they had a good result, excellent result in five of the cases. This is a technique for the Mayo Clinic, and they described the bone plating technique, and they used bone graft harvested from the ilium as a bone plate, and they used this bone plate as a fixation device and osteosynthesized this bone plate with the screws on the non-union side, and they had very good results, and most of the patients healed the non-union side. And as we said before, for a low demand patient with a small proximal fragment, we can take out the fragment, and we have to reattach the triceps to the proximal ulna, but we have to be very precise on the reattachment side, because the triceps should cover the backside of the humerus, and otherwise stability may come. And of course, this is a challenging case of the infection. It's not so common, but sometimes you can see, especially after high energy fractures, infected fractures, and we have to follow all the algorithm, and Professor Salabras very clearly described this algorithm, and we have to focus on the surgical debridement, because we have a septic non-union, infected non-union. We have, as he said, 2 goals: infection and union, and we have to take out the infection, we have to take out the microns, and then achieve the union. So you have to follow the surgical debridement. It should be thorough debridement, no devitalized tissue or necrotic tissue, antibiotics, management of the bone loss, stable fixation, absolutely necessary, and flap coverage in some cases will be to cover the soft tissue defect. Regarding the malunion of the proximal ulna, usually this is a result of the transelectron fracture dislocation or anterior montegia, anterior posterior montegia fracture dislocation. And the problem of the non-union or the malunion of the proximal ulna usually is reduced range of motion, flexion, extension, and rotation of the forearm, pain, and eventually arthritis. If we see in the literature, there are not so many studies regarding the malunion of the proximal ulna. And this is a very recent study, the recent year study, the PUDA study, evaluating the reduction of the dorsal angulation of the proximal ulna after fracture. And this is a study, almost 50 patients were treated surgically for proximal ulnar fractures, and they had about 30% malunion, defined as malunion more than 5 degrees difference between the fracture and the contralateral elbow, and this resulted in about 20 degrees loss of total elbow range of motion of the total loss of range of motion of the elbow. Another study regarding the varus malunion, they saw that when the varus restored versus not restored, there was a loss in the total range of motion, elbow flexion and rotation about 6 degrees, but this number did have a significant impact on the clinical outcome of the patient. This is an interesting study. This is a young adult with anterior montegia treated conservatively. And as we can see, there is still remaining arterial dislocation, subluxation of the radial head. And it's interesting to see the straight line. The posterior cortex is healed in this posterior line. This is called malunion. And what we have to do in this case is open reduction, with posterior approach, open reduction of the radial head and a wedge osteotomy so that we can retain this, the reduction of the radial head. This is an intraoperative image. We can see the reduction of the radial head and stable plate fixation. So overall, for these cases, non-union, malunion of the proximal ulna, we have always to very thoroughly evaluate the clinical and the imaging data of the patient. We need absolutely anatomic reduction, absolutely stable fixation, usually a posterior plate, bone graft may be necessary, and staged procedure may be dependent in cases of infection. Thank you.